Hi, welcome back. It's time for Chapter 3, and that's heart-lung interactions in health.
So we're going to begin our Chapter 3 and talk about heart-lung interactions in health. So this chapter will begin the synthesis of the Guyton and Campbell analyses, and I think that this juxtaposition of these two illustrative physiologic analyses can help maybe clarify some of the complicated and sometimes contradictory physiologies that are occurring during the normal respiratory cycle. And again, in Chapter 3, we're really supposing that the hypothetical patient that we're looking at in each of these examples is a normal patient with normal chest wall compliance, normal pulmonary compliance, normal airways resistance, is depicted on the, in this case, in the z-axis on the Campbell analysis, and normal cardiovascular tone, normal cardiac function is seen on the Guyton analysis. We think of these interactions quite often as effects of the respiratory system upon the cardiovascular system, and much of my illustrative slides will go through the methods or the means by which the respiratory system can interact with the cardiovascular system, but there's definitely reciprocity. And it must be stressed that normal respiration in the healthy patient has very minimal effects upon the cardiovascular system, and that is because, as we'll see, the two main mechanical mediators of heart-lung interaction are changes in intrathoracic pressure, which are minimal during normal inspiration, and changes in lung volume, which again is minimal in the normal patient. But using this as a basis for understanding the disease states will make the following chapter a little bit more understandable. And that's what I just said. So from the Campbell analysis, as I mentioned, the key variables of respiration are pressure and volume, that is intrathoracic pressure or pleural pressure, which I tend to use interchangeably. This is admittedly an oversimplification of what's going on in the thorax, but otherwise it would be very difficult to explain these interactions. So we're going to look at these changes in lung volume and intrathoracic pressure. And while lung volume can only change, that is, lung volume can increase or decrease by shifts in the transpulmonary pressure. And again, remember, the transpulmonary pressure is your alveolar pressure less the pleural pressure. That's essentially the distending pressure of the lung and what causes the lung to increase in size. Lung volume, as we know, can increase within a milieu of increased or decreased intrathoracic pressure, and that's essentially the difference between mechanical and spontaneous ventilation. That is, transpulmonary pressure during spontaneous ventilation goes up because the pleural pressure drops relative to the alveolus, whereas in mechanical ventilation in the sedated and potentially paralyzed patient, the transpulmonary pressure increases because alveolar pressure rises relative to pleural pressure. In both cases, the transpulmonary pressure is increasing. So this Venn diagram kind of neatly parses out these differential effects, and it may seem a little bit obvious, but what's common to both spontaneous ventilation and mechanical ventilation is that there's an increase in lung volume. An increase in lung volume in and of itself has cardiovascular effects. And in the literature, you can tease out the effects of volume versus pressure kind of by the changes that are seen in the cardiovascular system that occur both as a consequence of spontaneous and mechanical ventilation, and that does not occur during particular maneuvers such as the Mueller and Valsalva maneuvers where lung volume does not change. So this effect can be sort of determined by subtraction of the other effects of this Venn diagram. So decreased intrathoracic pressure is a Mueller. That is only a decrease in intrathoracic pressure without an increase in lung volume. So this is, you can imagine if you closed your glottis and started activating your muscles of inspiration, kind of sucking against a closed glottis, you'll lower your intrathoracic pressure, but you will not change your lung volume. So you're not changing your transpulmonary pressure, you're only dropping your pleural pressure. And you can look at the effects of the cardiovascular system in this situation. Again, it's a little bit this is a little bit of an oversimplification. A Mueller maneuver really implies a very forced, prolonged inspiratory maneuver, usually in the order of 10 seconds or so, with intrathoracic pressures dropping in the 30 to 40 below atmospheric pressure. And if you're taking a normal inspiratory breath in, you drop your pleural pressure only a few centimeters of water. So it's a little bit of an exaggeration certainly is an exaggeration of the normal physiologic response, though in pathological states, as we'll talk about in Chapter 4, the decreases in intrathoracic pressure during disease states such as a profound obstructive airways disease or profound decreases in pulmonary compliance, pleural pressure can drop as much as it does during Mueller maneuver. And then clearly, if you were to combine a drop in intrathoracic pressure and an increase in lung volume, these two effects together, this is spontaneous ventilation. Similarly, you can analyze only the effects of intrathoracic pressure, and this, as I think we all know, is a Valsalva maneuver. That's increasing your intrathoracic pressure against a closed glottis, so you're increasing pleural pressure, but there's no change in your transpulmonary pressure, and therefore no change in your lung volume. So pleural and alveolar pressure essentially increase to the same extent. And then if you're to summate these two, an increase in intrathoracic pressure and an increase in lung volume, and this is an intermittent positive pressure breath or intermittent positive pressure ventilation. And before I click again, I would just want to say that these effects tend to demonstrate or create transient stresses upon the cardiovascular system, and this is very nicely described in a few review articles from maybe 20 years ago or so by Fessler and Saul Permut, where they talk about the different stresses that inspiration has on the cardiovascular system and how they can be transient as they occur with a breath where there's an inhalation and an exhalation versus steady state effects. And that's really often we're talking about the application of a positive end expiratory pressure. That's a pressure, or that's a stress upon the cardiocirculatory system that essentially is applied and then doesn't really change breath to breath, and that has tends to have more profound cardiovascular effects. So this chapter will be broken down essentially into these parts. We're going to talk about each of these things in turn. So I think there'll be about 6 parts to this chapter. So we'll start off by looking at just the middle portion of that Venn diagram. What does a change in only lung volume occur? What does a change in only lung volume do to the cardiovascular system? And again, so this is something that will occur during both spontaneous ventilation and mechanical ventilation, because in both those situations, lung volume is increasing. So as I mentioned, lung volume increases in response to an increase in transpulmonary pressure, whether it's mechanical ventilation or spontaneous ventilation. And alveolar pressure rises relative to the pleural pressure, so this is the increase in transpulmonary pressure with mechanical ventilation, whereas in spontaneous ventilation, pleural pressure drops relative to the alveolar pressure, and this is the result of the muscles of inspiration. But the increase in lung volume, it's important to understand that this tends to compress the cardiovascular system in general. It actually can compress the heart itself if lung volumes are very large. But more importantly, the increase in lung volume tends to compress the pulmonary vascular bed and also the abdominal bed. And the key physiologic perturbation that occurs in this situation is that you change venous capacitance or vascular capacitance. And what that does is it changes pressure heads for flow. And I think maybe the best silly analogy I can think of this is if you imagine your abdominal splanchnic bed to be the venous capacitance bed. It contains a very large portion of your blood volume. Your venous capacitance beds in totality contain about 75% of your blood volume. If you think of that as like a water bed, it has a certain transmural pressure that gives the water bed kind of an elastic recoil, and what that does is it provides a pressure within the water bed that if you were to open up the cap on the water bed to let the water out, essentially that's what would drive flow of the water out of the water bed. So it's how full that water bed is essentially like your unstressed and your stressed volume, that is your mean systemic pressure, or how compliant the bed itself is the pressure driving the water out of the water bed. But if you were to lie on the water bed, you would tend to compress it, and then you would tend to favor flow out of it. And that's essentially what decreasing your vascular capacitance is doing. So the overall effect of circulatory compression depends parenthetically on the volume status of the cardiovascular system. So if the waterbed is completely full and distended and ready to burst, and then you lie on it, this is going to have a much more profound effect on the flow of water out of the waterbed, or as the analogy, or in the organism, it would be an increase in venous return, say, whether it be systemic or pulmonary venous. Whereas if the waterbed were kind of empty and you were to lay on it, it might not increase venous return at all, and in fact you could make an argument that you could actually diminish venous return if you were impairing the resistance to flow out of the system. So that leads to this first slide, which is abdominal circulatory interaction, and this is really what increasing lung volume does on the abdominal splanchnic bed. And so increasing your intra-abdominal pressure, so when you contract your diaphragm, the transdiaphragmatic pressure increases. That is the pressure in the abdomen. Again, this is a function as to whether your diaphragm breathing or you're breathing with your intercostal muscles, or your accessory muscles of respiration. But a normal breathing, and this is a normal patient, you contract the diaphragm drops, the volume of the abdomen decreases, and therefore the pressure in the abdomen increases, a function of the abdominal compliance. So the pressure in the abdomen increases, the pleural pressure decreases, but this increase in pressure kind of compresses the abdominal splanchnic vascular beds, and you functionally increase your mean systemic pressure. And this is what an increase in lung volume does. You're essentially, as you decrease the capacitance, you're basically recruiting unstressed volume in the splanchnic vascular beds into stressed volume. So you functionally increase your mean systemic pressure, so you shift your venous return curve rightwards, and this favors an increase in venous return into the thorax. But as you can imagine, the increased intra-abdominal pressure tends to collapse the IVC, and it probably also collapses hepatic vascular beds, that tends to diminish maximal venous return, and this effectively increases the resistance to venous return. And you can see that when you ultrasound somebody's IVC. So this is the little cartoon I use frequently in my slides, where this is the patient lying on their back, this is their chest, this is their chest wall and their heart, this is their pressure in the abdominal compartment, this is your IVC, and this is blood flow that occurs when you inspire. Your right atrial pressure drops, there's a bit of a gradient, and blood flow into the thorax is favored. But as I mentioned, your abdominal pressure is simultaneously increasing, and what that can do is lead to this fluttering or collapsing phenomenon, which causes this plateau portion, or maximal venous return. And this is going to be highly dependent on the patient's volume status. I think this was really first, it was actually initially described, this physiology was described in the early 60s by Saul Permut in terms of how this works in the pulmonary vascular bed, and his description of the vascular waterfall phenomenon. And then it was more quantitatively described by his group, I think it was his group in the mid-80s, it was Brower and colleagues, 1985 maybe, and they showed that this occurs in the pulmonary vascular bed, which I'll show you in the next slide. And then this physiology was then applied to the abdominal compartment in the mid-90s by Takata and colleagues. Well, they essentially showed that if your abdominal compartment, if the splanchnic venous beds in your abdominal compartment were essentially like West Zone 3 physiology, and you can sort of think of those as plump, full vessels, and you compress the, you increase intra-abdominal pressure, you tend to augment IVC flow. So you follow this curve. So you can think of this, if your baseline volume status is high, you follow this curve. Whereas if you're hypovolemic, or your abdominal vessels are kind of in the so-called West Zone 2 physiology, well then actually increasing abdominal pressure tends to collapse the IVC and many of the venules that are confluent into the IVC, and it tends to functionally increase the resistance to venous return, and you may actually get this, you may drop your maximal venous return and therefore decrease venous return as a whole, even though you're also simultaneously functionally increasing your mean systemic pressure by compressing the splanchnic beds. So I've said most of this already, that this would represent a patient who's very volume replete or hypervolemic when the vascular pressure is much higher than the abdominal pressure. So increasing the abdominal pressure tends to squeeze blood back towards the thorax, whereas if the patient's volume deplete and the vascular pressures are much less than the abdominal pressure, then increasing the abdominal pressure tends to impair venous return. So this is actually a really important concept. This isn't just something that's for interest's sake, that you see patients who are hypervolemic and hypovolemic all the time, and the functional impact of them increasing their lung volume, whether they're on a mechanical ventilator or spontaneously breathing, can have profoundly different effects on venous return to the right heart. And we explore a little bit more of this in subsequent chapters. And as I mentioned, I think I mentioned this already, that this was initially described in dogs, and dogs actually have an intrathoracic IVC that can collapse. Where in humans, there is no intrathoracic IVC. It's the increase in venous resistance probably occurs by compression of the hepatic venous system. So this is the exact same physiology, and even though I'm showing you this slide second, this physiology was actually elaborated first and it was applied to the abdominal compartment. So it's essentially the same, that if you increase transpulmonary pressure or your lung volume, and that's whether you're increasing alveolar pressure relative to pleural pressure or lowering pleural pressure relative to alveolar pressure, the physiology is the same. There tends to be diminished venous return from these compartments. So this is zone 1 and zone 2 physiology. Again, zone 1 occurs when pulmonary arteriolar, pulmonary capillary, and pulmonary venular pressures, vascular pressures, are all below alveolar pressure. Zone 2 occurs only when alveolar pressure supersedes pulmonary venular pressure. And zone 3, pulmonary arteriolar, pulmonary capillary, and pulmonary venular pressures are all greater than alveolar pressure. So when this patient inspires, if you look at these little resistors that are implying an increase in lung volume, these tend to collapse. You drop your venous return, and even though you tend to decrease, and again, this is somewhat of an oversimplification because it depends on where you are relative to functional residual capacity. But if we assume that this patient was beginning at functional residual capacity and they increased their transpulmonary pressure, they would functionally increase their mean systemic pressure or their driving pressure because they're collapsing their overall decreasing their pulmonary capacitance. But if they have a very high fraction of zone 1 and zone 2 physiology, that is, they're hypo or euvolemic or hypovolemic, there may be not much, or even in theory, a decrease in pulmonary venous return. It's probably more of not much of an increase. It probably stays close to baseline. Whereas the higher the fraction of zone 3 physiology, as you increase lung volume, there tends to be an augmentation of flow, so that patients with a very high fraction on their lung of zone 3 physiology would tend to have a curve like this. So there'd be, you can imagine a heart failure patient whose entire lung may be zone 3 physiology. Every time they increase their transpulmonary pressure, they're actually bolusing their left heart, and they're augmenting pulmonary venous return. So that was the effect on venous return of an increase in lung volume. But what about the effect on the cardiovascular system, or the cardiac function curve? It certainly occurs. And it's essentially just understanding how the physiology I've just talked about affects the heart. So compression of the pulmonary vascular bed increases pulmonary vascular resistance, which contributes to an increase in the pulmonary arterial impedance. This will be more pronounced with very large increases in transpulmonary pressure and therefore lung volume, and when there's a large fraction of zone 1 and zone 2 physiology in the lungs. At very high lung volumes, the cardiac chambers can be compressed within the cardiac fossa, and this can induce biventricular diastolic dysfunction. The data for this in humans is not great, save for in the severe COPD patients with air trapping. So again, this is kind of 1960s physiology, but you've probably seen it in your John West books. That if you were to increase lung volume from its collapse state, or the pulmonary equilibrium volume that we talked about in Chapter 1, as you increase the volume or the transpulmonary pressure above that point, the extra alveolar vessels are tethered open. And what that does is it increases their capacitance to retain blood, and it also decreases their resistance for blood flowing through them. And it tends to follow a curve like this. Whereas in the alveolar vessels, and again, this is less of an anatomic, the distinction between alveolar and extra alveolar vessels is less of an anatomic distinction and more of a physiological distinction. The physiological distinction is essentially when the transpulmonary pressure supersedes the transmural pressure of the vessel, then you start to have alveolar type blood vessels, whereas when the blood vessels are exposed to the more to the pleural pressure, then that's more physiologically an extra alveolar vessel. And the alveolar vessels are in fairly close apposition to the alveoli, and if you were to increase the lung volume from the lung equilibrium volume up to TLC, the resistance tends to increase as these, you can sort of think of it as the alveolar capillaries being compressed, and that also tends to decrease their capacitance, and so it creates this kind of nadir at FRC where pulmonary vascular resistance is the lowest, and therefore pulmonary vascular capacitance is the highest. And so the summation of the two creates this U-shaped curve, and so the minimal resistance is found near functional residual capacity. So the cardiac function curve and lung volume. In my lectures, I'm going to try and color code that to try and tease out some of the effects of heart-lung interaction. You'll see that I'll color code the right ventricular cardiac function curve in blue and the left ventricular cardiac function curve in red. So what does an increase in lung volume do? Well, an increase in lung volume above functional residual capacity will tend to shift the cardiac function curve down and to the right, and this is mostly because of the really the increase in afterload on the RV, as we just saw. As you increase pulmonary vascular resistance, vascular resistance is a component of outflow impedance. You increase the outflow impedance, and the ventricle can only eject a given amount of blood at a higher filling pressure, which is functionally a shift down and to the right of the cardiac function curve. And again, in a healthy patient with a normal lung volume, normal transpulmonary pressures, this interaction tends to be quite minimal. As I've mentioned, at very high lung volume, this is what we're talking about in Chapter 4, there can be a diastolic dysfunction that can occur. But again, that usually requires fairly high lung volumes. What about the left ventricle? Well, again, the left ventricular cardiac function curve is in red, and again, you can see this point here, that this x-intercept I've highlighted here, and that's because, as we talked about in Chapter 2, and as I talk about frequently in these heart-lung interactions, this is a very important point because this point really tethers at least right ventricular cardiac function curve to changes in intrathoracic pressure, and that's because if you were to arrest the circulation, that is, make blood flow on the y-axis 0, and you were to, in this situation, uncouple venous return from the heart, so you'd have to essentially clamp the SVC and the IVC. If you were to measure the pressure in the right atrium, well, that would take on the pressure of, it's essentially a marker for your intrathoracic pressure. It would become intrathoracic pressure if venous return would not occur. So this point's kind of important, and it's generally slightly subatmospheric for the right ventricular cardiac function curve. For the left ventricular cardiac function curve, in reality it's shifted somewhat to the right because of the thickness of the LV, so not as much of the intrathoracic pressure is transmitted into the left ventricle, so it's somewhat buffered from that effect. In my cartoons that I show them essentially at the same point, but it's not entirely accurate. It's just for simplicity. At normal lung volumes, the left ventricle can be compressed by an expanding lung, given its anatomic proximity. The LV kind of, as you know, lies posteriorly near the lung. But with normal increases in lung volume, this tends to be minimal. And there really isn't a generation of a diastolic dysfunction. That is, as the lungs compress the LV, it's been shown that even at fairly moderate increases in lung volume, and certainly with PEEP, as we talk about later, which increases lung volume, which would mimic this effect, that while the pressure in the LV does tend to increase, which would tend to suggest a diastolic dysfunction, that is a higher pressure for a given output, that in these patients, when they have their lung volume increased and the LV is impinged upon, that if you maintain end diastolic volume, cardiac output stays the same. So it's kind of a pseudo-diastolic dysfunction. So in summary, illustrating the impact of an isolated increase in lung volume is somewhat artificial because lung volume really only changes by a change in transpulmonary pressure. These last slides were just for illustrative purposes. Superimposing the Campbell and Guyton analysis, which is the topic of this chapter in Chapter 4, and a smattering of my slides in Chapters 5 through 8, can give us pictorial representation of this interaction. Whether by mechanical or spontaneous ventilation, increase in lung volume changes systemic and pulmonary venous capacitance, as we saw in those previous slides. And therefore, the increase in lung volume tends to augment systemic venous return, particularly from the abdominal splanchnic beds, and pulmonary venous return to the left heart. And as we saw, lung volume expansion tends to raise right ventricular afterload. So just for a very brief review of what this Campbell diagram is, for those of you who skipped Chapter 1, some of the feedback I've received is that it's confusing as to, the Campbell diagram that I depict is kind of static. And yes, this is a static pulmonary compliance or pulmonary elastance curve, and this is a static chest wall elastance curve, and this is functional residual capacity, the volume that occurs when the chest wall is at rest. And I talked a lot about this in Chapter 1. And so what's actually happening during an inspiration, this is sort of what's happening. I'm trying to animate it here to make it a little bit more intuitive. But with a spontaneous inspiration, lung volume increases while pleural pressure decreases. So again, this is your pleural pressure or intrathoracic pressure at FRC. So this is kind of at end expiration. You're just waiting to inspire. And then what happens is this is chest wall diastole. This is the pressure volume relationship of the passive or non-contracting chest wall. When you generate an inspiratory breath, the chest wall curve shifts leftward. This is a little bit inaccurate. It doesn't really maintain the same shape. It tends to become more comma shaped. But the important point is that during an inspiration, the compliance characteristics of the chest wall is changing as the muscles of inspiration are activated. And you can see then what this does is it causes a decrease in your pleural pressure, and you have this increase in your lung volume from here to here, here to here. And this additional curve to the left of the static pulmonary elastance curve, this additional curve represents the additional amount of pleural pressure that has to be decreased to overcome the resistance to airflow. Then during a passive expiration, the chest wall returns to its previous resting state, and you return to functional residual capacity. And that's essentially the change in pleural pressure that you get with a spontaneous inspiration. With a passive, and when in all of my lectures when I say passive mechanical ventilation, passive means that the patient is fully adapted with the ventilator, and that usually requires deep sedation and potential paralysis. And so that means they're not shifting their chest wall elastance or chest wall compliance curve at all. It's their muscles are completely put down. So in that patient, the ventilator is doing all the work, and in that patient, the change in pleural pressure is a function of the change in volume that you've dialed into the ventilator. For instance, if you're using a volume limited mode of ventilation, and it's determined by the chest wall compliance. And I talk about why this is pretty extensively in multiple chapters. The impact of increased lung volume on the cardiovascular system can be depicted by, the reason I've gone through this Campbell analysis is just to remind everyone what this Campbell diagram is, and that marrying the Campbell and Guyton analyses can illustrate these heart-lung interactions. So again, this is the Campbell analysis that we just saw. This is the Guyton analysis that we talked a lot about in chapter 2. And again, I do talk about this at the end of chapter 2. If you were to drop the Campbell analysis down into the z-axis, so this axis is going into the page, and you're keeping pressure on the x-axis, and you can do that because remember, the Campbell analysis has pressure on the x, and so does the Guyton analysis. So you can superimpose these two analyses, sort of like what Guyton did for the superimposition of the Frank-Starling relationship and his venous return relationship. And you can begin to represent how the heart and lung interact, and how changes in pulmonary elastance, dynamic properties or airways resistance, chest wall elastance, how changes in those characteristics of the lung and chest wall result in changes in intrathoracic pressure, and then how changes in intrathoracic pressure are actually distributed to manipulations of the cardiovascular system. So this is what I've mentioned. The Campbell analysis is on the z-axis, and the Guyton analysis remains on the xy, again x being pressure, and in this case y being cardiac output in liters per minute. So what happens with an increase in lung volume? Again, this is the Campbell analysis in the z-axis going into the page. So again, this is completely hypothetical, but regardless of a change in intrathoracic pressure, if you were to just increase the lung volume, as we've talked about, it affects both the venous return and the cardiac function curve. So this would be like hypothetically just increasing along the z-axis here without any lateral changes in intrathoracic pressure. Again, this is totally hypothetical, doesn't really exist because changes in lung volume can only occur by changes in intrathoracic pressure. And as we talked about, what this does, the increase in lung volume shifts the venous return curve to the right, but may or may not increase venous return depending on the patient's underlying volume status. So we see that here, that you've shifted your mean systemic pressure by decreasing the capacitance of the, say, the abdominal splanchnic beds. But whether or not venous inflow to the thorax is augmented as it is here versus here really depends on the underlying volume status of the patient. In this situation, the patient would be hypervolemic. They would have a predominant abdominal west zone 3 physiology, whereas in this patient, they would have abdominal, quote-unquote, abdominal west zone 1 or 2 physiology. This patient would be more hypovolemic. And so that was that analogy of laying on a waterbed, how you decrease its capacitance, and depending on the baseline volume status of the waterbed, you would either augment flow out of the waterbed or not. Okay. And then again, depending on the degree of lung volume, if you go very much above functional residual capacity and you tend to cause compression of the alveolar vessels, you tend to increase pulmonary vascular resistance, the right ventricular afterload will increase. Diastolic impairment from lung expansion, again, only typically occurs under very pronounced increases in lung volume. So the shift down and to the right of the cardiac function curve here is determined mostly by this increase in right ventricular afterload, or the increase in pulmonary vascular resistance. So that was it for the first part. We talked about that middle part of the Venn diagram, changes in lung volume. We saw how it affected both systemic and pulmonary venous return, and also how it affected the cardiac function curve. This next portion of the chapter, we're going to move on to how only a decrease in intrathoracic pressure affects the cardiovascular system without any changes in lung volume.